inviting me to speak on a topic which has fascinated me for the last 15 years. So this is what in 2024, towards the end of 2024, the ISM work group said that to start with, the term atypical HUS is confusing, it does not reflect pathogenesis and needs updating, and probably thrombotic microangiopathy rather than atypical HUS is a better terminology. So if we are going to call these diseases thrombotic microangiopathies, what does that entail? It means that we recognize a clinical syndrome which has microangiopathic hemolytic anemia, thrombocytopenia, very often hypertension, and then we attempt to segregate these patients into a group where the disease is either driven by a 1 milligram factor-cleaving protease deficiency, that's TCP, the overactivity of the complement pathway, that's what we have been calling HUS, or various secondary causes. Unfortunately, it's not always that simple because the disease often does not present with a full-blown picture of thrombocytopenia and microangiopathic hemolytic anemia. It's often renal limited. It may just present with urinary abnormalities. The right settings may make a difference. It's pretty common in the postpartum period, and also in India and Sri Lanka, it has been reported with vascular. So this is an algorithm of diagnosis that has or workup that has been suggested, and most of these tests are now fairly easily available. We try to establish the diagnosis and then try to either exclude or rule in a particular etiology. With the advent of the molecular-based sepsis panels, which are freely available, PCR-based panels, we now get a report for cigatoxin 1 and 2 or even pneumococcus very rapidly. Within about a few hours, we are able to rule out or rule in a cigatoxin. And we are also now starting to do CD46 by flow cytometry on peripheral mononuclear blood. So the diagnosis is becoming simpler, faster, but a lot of questions still remain. And as you can see, there are a lot of mimics. The SLEs will have thrombotic microangiopathy sometimes as an accompanying feature. There can be many other mimics, and as I said, the pathogenesis is still in doubt in some situations. I won't go into this. Dr. Bansal showed it. It's common whether you are talking about thrombotic microangiopathy or C3 glomerulopathy. But there is an element of crosstalk between the complement system and the coagulation cascade, especially when the lectin pathway is involved. And that may be the reason if the coagulation cascade additionally or there is endothelial damage is activated, then that may determine the surface versus fluid phase activation, which determines whether a patient will get a C3 glomerulopathy or a thrombotic microangiopathy. If we are going to investigate it, then we could do, when we are investigating the complement system, we can do functional assays or we can look at individual components, and which sample we collect, how we collect and transport it in this situation becomes important. If you're looking at functional activity, you need complement preserved serum, so you allow the sample to clot, separate off the serum and handle the sample on ice. Because in vitro activation of the complement system, a takeover can start and give falsely low functional values for assays like CH50 and AH50. And also within the lab, if there is repeated freezing and thawing of a sample, again activity assays will give you false low values. So when we receive a sample in the lab, we immediately aliquot it, and each time we have to run it, we use one aliquot at a time and preserve the rest at -80 degrees till they are required for discard. If we are looking at individual components or we are looking at an ADAMTS13 activity assay, then we need secreted plasma which comes in the purple top vacuum container, and these also require to be transported on ice. The calcium that gets chelated by EDTA inhibits the complement activation in vitro. So CH50 and AH50 are two functional assays that we use. We use an ELISA which has a good concordance with the original hemolytic assay, where CH50 used sheep RBCs and AH50 used rabbit RBCs. The commonest cause, as has been mentioned in this article, is improper handling of a sample, which allows in vitro activation of complement pathway. There are also some caveats. There are CH50 activity is low or moderately reduced in neonates. It may also be present because in the low activity may reflect either consumption or a congenital defect of certain pathway or of certain components of the pathway, and cold activation which may occur with certain cold agglutinins which do not specify. When we interpret the AH50 and CH50 together, they give us a complete picture of what is happening to complement activation. So absent AH50 in the presence of a normal CH50 suggests a pure alternative pathway, the component deficiency or overactivity with consumption of the component. And normal AH50 on the other hand with a low CH50 suggests a classic pathway deficiency. So this is what has been the algorithm suggested about 9 years ago by in the American Journal of Hematology. Run a CH50 and an AH50 together. You could either get both of them normal or both of them low, or you could have a normal CH50 with a low AH50. That's a complement. That's an alternative pathway overactivity or deficiency. And if you have a normal CH50 with a low, if you have a normal AH50 with a low CH50, that's classical pathway. It's not only the alternative pathway overactivity which results in AH and C3GN, but also endotoxic shock which can result in a low AH50 activity. In this situation, however, the CH50 activity is also low and acute phase reactions will be increased. Perhaps the test that we are asked to do the most, we received over the last 10 years thousands of samples, is the antifactor antibody assay, for which we use an ELISA. Now, this test has been standardized in three reference labs in Europe. The only laboratory currently in India which does the standard method is All India Institute of Medical Sciences. What we did is to use a commercial ELISA and standardize it against the Newcastle lab. They taught us a few important steps and a few important things when we were doing this assay. The assay, we found that the linearity is preserved up to a dilution of 6,400 times. The results are expressed in arbitrary units and each population has to have a normal value set. So what we did is to take healthy blood donors who and run the assay in adults and in school children coming for a routine school checkup for children. The value is given, you construct a histogram. If the histogram is not normal, then you go for a log of the OD and then compute standard mean and 3 standard deviations plus minus 3 standards gives the range. And when we did this, we find that our cutoff of normal is about 100. So this is, as I said, the standardization that was done. And when they did this, they picked the Paris assay as the most stringent and the most likely to pass the 100 arbitrary units cutoff. They also evaluated a commercial ELISA at that time against the standard method and showed that there were certain deficiencies in the commercial assay, which I'll show you in a minute. Now, we run a positive and a negative control with each run, and the validity of the assay depends on showing that there is a difference of at least 1 OD units between a positive and a negative control when the ELISA is run. There is also, though the manufacturer tells us that lipemic and hemolytic samples do not affect the assay, the Newcastle lab taught us that this does happen. And what they did was to tell us to run something called a sample-specific background assay on each sample, where the reagents are not added, but the sample is coated on the ELISA well and run for an OD, which is then subtracted. This is what happens with the commercial assay at the upper end of the At the upper end, the values tend to cluster together. So this is the reference method, and the commercial assay will tend to underestimate the values at the upper end. What we do is to dilute this with 5 molar sodium chloride at the start of the assay, and that tends to improve this. And then, of course, you have to multiply by the amount to which the sample is diluted in the assay. So we do a 20 to 50 fold dilution, pre-dilution of the sample before running the assay. We also found that when we ran the sample against the Newcastle standard, the kit ELISA standard was about 8 times lower. So that's where we managed to find out what we should standardize. We asked for the standard. They said, sorry, we can't give it to you. We are running short ourselves. So what they suggested was keep certain reference samples. When we sent one of our samples to Newcastle, they gave us a value of 1,32,000, and he wrote back saying, since the lab started, this is the highest value I have ever seen in an assay. So we keep positive and negative samples now as standards and run them each time when batch of the assay is done. So as I said, we need 60 microliters. The linearity, we ensure that by dilution, the ELISA OD readings are between 1 and 2.5, because beyond that, the linearity tends to fall off. The antibodies, only free antibodies and not complexes are detected, and repeated freezing and thawing of samples needs to be avoided, so we aliquot the samples when we first. This is the interpretation of the anti-factor VIII antibody. It correlates better with C3 levels inversely and not with factor VIII levels, and value of more than 8,000 at presentation predicts likely non-responsiveness, and low C3 levels during the acute phase were also associated with a poor prognosis. Also, this is a paper from All India Institute of Medical Sciences in 2019, in which they followed up their patients and they found that if you had an anti-factor VIII titer which had come down with treatment and began to rise again, a value of around 1300 and a value of around 440 for factor VIII predicted relapses, and they reported this especially at the time of COVID. There were patients who had been stable in their series for more than 5 to 6 years who relapsed at the time of COVID, so along with a rising. So this is what the KDIGO says regarding genetic testing in HUL. Search for rare variants using whole exome sequencing. Analyze copy number variation, because these will be missed. Hybrid genes could be missed by NGS. Search for DAGKE and sequence the ADAMTS13 gene, and also look for the C5 polymorphism, which will predict eculizumab non-responsiveness. So complete genetic panel in an HUL would mean doing all of these things. This was shown. I won't go into the results. The series from the West report that 20 to 30% of all HUS cases have factor VIII mutations. C3 is much less. Hybrid genes vary by cohort, and these are detected as copy number variations. And of course, the absence of a detectable variant does not preclude a genetic form, because the number of genes being added to the panel is steadily increasing. I find this particularly interesting. What are the chances of picking up a genetic variant? The two-hit hypothesis tells us that you have genetic susceptibility and endothelial damage. If the endothelial stressor is a very strong one, like anti-factor VIII antibodies or citotoxin, then you are far less likely to require a genetic susceptibility. These are sufficient in themselves to produce a thrombotic myopathy. On the other hand, malignant hypertension, pregnancy, and undefined AHAS are conditions where a genetic susceptibility is far more likely to be found. One study says that in malignant hypertension patients who had TMA, the incidence of genetic mutations was 80% versus 5% in those malignant hypertensive patients who did not have a TMA at present. So this looks interesting. It would look at the chances of picking up a variant on genetic analysis. And this is our own data. The Indian Society of Nephrology West Zone gave a grant to KM Mumbai and KM Pune together, and we analyzed 37 samples. We have also another 25 which are running right now. And what we picked up was 4 factor VIII pathogenic mutations. What was surprising to me was we found 4 ADAMTS13. The literature tells us, except for one paper by Agnes Veradia back in 2009, that ADAMTS13 is associated with TTP with relatively mild damage. But we found, including one family where 2 siblings, young children, had ADAMTS13 mutations. One of them died at 1 year of age, and the other developed ESRD at the age of 12. So we're finding a good number of ADAMTS13. We also found 2 novel DAGK mutations, and recently an inverted forming 2 mutation in a 19-year-old. So this was the DAGK paper that we published 2 years ago in IgN. The NTS panel Illumina TruSight did not have the DAGK gene at the time, so the lab had to order it specifically out. This is the copy number variation, and this is what is not picked up by NGS. So this is a hybrid gene of CFH and CFHR1, and this is how the MLPA looks. As you can see here, the CFH exon 23 has 3 copies, with the capillary electrophotogram is giving a 1.5 times higher signal, and the CFHR1 exon 6 is showing a half intensity signal. So there is a triple copy. This has been transferred to this point, and you get a hybrid gene and a protein which competes with CFH. Now, when we submitted this paper, the reviewer said, okay, you found a mutation, but how do you know it's what's driving the disease? So fortunately in HUS there is a functional assay which does normal human plasma protects sheep RBCs from complement mediated lysis, whereas if there is factor H dysfunction, then in vitro with a CFTD buffer you will get an increased lysis of sheep RBCs, and that's what we did. This method has also been shown in the literature to be useful in classifying new variants of unknown significance as pathogenic or harmless. So in this, two new variants which had single nucleotide polymorphism were added to pathogenic to serum from known pathogenic mutations, and far from enhancing hemolysis, the hemolysis was inhibited by the new variant, proving that this variant of unknown significance was likely non-pathogenic. On the other hand, in our patients, what we found was a steady increase in hemolysis, which was inhibited when we added control plasma, and in all situations it was much more than the control. So this proved that this suggested that this variant was likely pathogenic. We have also shown that the hemolysis is more in acute serum and decreases in convalescent serum, and this is a paper from Caroline Blanc which showed that antifactor antibodies in HUS provide much more hemolysis than those in C3G. So this is one way of distinguishing whether an antifactor antibody present would be likely to produce C3GN or A. So that's the utility of the assay. There's also another test, and that is a modified HAMS test which can be done. In the HAMS test, we're looking at PNH. In PNH, we're looking at RBCs which are deficient. Here we add GPI, glycosylphosphatidylinositol anchor deficient cells to the patient's plasma and look for hemolysis. And there's also a modification of this test which we are establishing using flow cytometry with specific cells, where plasma from suspected patients can be detected. So, if I had to summarize about the investigation, classification of complement gene variations and standardization of antifactor antibodies and these measurements are crucial in management. And currently, there is the profile of secondary and complement-associated biomarkers may be similar. There's one reference method, human microvascular endothelial cell 1 line, which is available in reference in a research lab, but not yet for big time. So this is what they say on, this is back in 2016, a statement which way back there said eculizumab should be a first line treatment, but they made a caveat that in antifactor antibody HUS and emergency treatment of critically ill patients with TMA or strong presumptive diagnosis of CTP, plasma exchange would be recommended. And even today, this is 2024 ISM workgroup, C5 blockade is the cornerstone, but if C5 blockers are not available, plasma exchange can be considered. There's no doubt about the value of eculizumab. These are 5-year survivals without and with eculizumab, it doubles. And it's most useful in CFH, CFI, and C3 mutations. And also, because across the world, eculizumab is expensive, it's injectable, there's been an attempt to withdraw it. Now, if you have a pathogenic mutation or a variant of unknown significance, then 1 in every 10 patient years, you will get a relapse on withdrawal. But if there is no rare variant, interestingly, 0 in 67 patient years was the relapse rate. So if there isn't a variant, it may be safe after the patient has been in remission for 6 to 12 months to withdraw eculizumab, is what lesson literature tells. In 2024, there has been a chorus for giving up plasma. I think the title of these two papers are from pediatric nephrology in April, and this one is in the Jackson of October, about 2 months ago. I think the title of this paper is Presumptuous, suggesting that a retrospective study of 15 patients with antifactor could question the need for plasma exchange, because we do have much bigger data on that. Now, this is from the Jackson paper, and it suggests that the only reason why plasma exchange is still being used is because the availability of eculizumab remains in doubt, and also because the diagnosis of TTP is rather more difficult to establish since the ADAMTS13 assay is not widely available. It's available to me. I get a report within 24 hours, so I guess I'm nothing. Now, this is what the paper from Jackson suggests, that you could start empirically treatment with tafasitamab or what is now available, recombinant anti-RMPS 30. And if you have ruled out TTP, you could start presumptively with a short-acting C5 blocker and then withdraw it if it or discontinue it if an alternative diagnosis is established. They say that use of plasma exchange delays the start of C5 blockers in patients with atypical. Now, there isn't any randomized controlled study on C5 blockers or on plasma exchange, and given the rarity of the disease, there probably never will be. So, what we left today is, this is a statement from the Indian Society of Pediatric Nephrology 2019, which tells us that unlike European cohort, where the incidence of anti-factor VIII antibody disease is about 5 to 20%, in Indian patients it's 56% in the AIM study. Dr. Aditi Sinha is the lead author of that paper. And recently a paper from SDPJ published in IgA about 2 months ago, I think, looked at a mixed cohort of adults and pediatrics, and once again the incidence even in adults is about 57% in that paper. So it could be that in this situation, plasma exchange and immunosuppression, which has been proven of benefit, and I'll show you the data in a minute, the initial suggestion from the ISPN work group was a very intense plasma exchange regimen, which was daily for 5 days or until hematological remission, and then a gradual taper over 4 to 6 weeks along with immunosuppression. And there's no doubt that that works. So this is from Dr. Sinha's paper. Patients who were treated with both combined plasma exchange and immunosuppression at 18 and 24 months had more than 80% survival. In patients who didn't receive the treatment, it was less than 40%. So this paper was a landmark paper. I think about 144 patients with anti-factor VIII antibody disease and excellent results with plasma exchange and immunosuppression. This is a paper from PG at Chandigarh, which looked at a much less intense regimen, 15 children. They reduced the number of cycles to 11. Severely ill patients, 46% of them were dialysis dependent, but at 12 months, the average eGFR was 90%. So even with a less intense plasma exchange regimen, and the same applied to the SDPJ study, where the average number of plasma exchanges was 7, that they still achieved remission in most of their patients. The patients who had antibody titers very similar to the earlier AIMS paper of 7,500 million responded less well to plasma exchange, to their regimen. They only used 7 plasma exchanges as a median, a minimum of 5, and still this is their survival rate. So renal survival was much better with plasma exchange in antibody positive disease as opposed to antibody negative disease. Patient survival was similar. So if we have to summarize, as I said, there will never be a randomized trial unless we in India do it purely in antibody positive disease. So patients treated with PLEX had severe disease, and yet the remissions are much faster. So PLEX reduces antibody titers within 7 days, whereas in eculizumab, they remain persistently elevated for a much longer period of time. And in fact, immune complexes of antibody and or antibody antigen may result that while eculizumab may abrogate the TMA, that there is a chance that these patients would eventually develop an immune complex glomerulonephritis. This diagram was already shown that there are multiple targets today available for attacking the complement pathway, and I'll look at a few of them. So ravulizumab is the first of these. There's also now there are trials with generic eculizumab now available. Ravulizumab is a longer acting monoclonal IgG4, and it has a half-life of 52 days versus 11 days. So it allows 2 monthly dosing, once in 2 monthly dosing, as opposed to once in 2 weeks for eculizumab. This is a study which has been looked at a 2-year efficacy and safety outcomes with ravulizumab in children and adults. One study was in adults and 2 cohorts of pediatric patients, C5 inhibitor name, and those patients who switched from eculizumab to ravulizumab. The endpoint was a complete TMA response, which was platelet count normalization and greater than 25% improvement in serum KS. And this was the trial flow, and this is what it achieved. The remissions were complete response was achieved in 61% of adults and 90% of children. The children did better even with ravulizumab than adults in this, while the response among naive patients, 86% of adults achieved platelet count normalization, and it was 95% in children who were ravulizumab, who were C5 inhibitor naive. So children did a little better than adults with Rahim. The lectin pathway has been targeted in TMAs, and it is specifically being used. Narsoplimab has been used in hematopoietic stem cell transplant induced TMA. The lectin pathway specifically is activated in this, and this is one study which looked at narsoplimab. 28 patients were enrolled in this study. Initially, narsoplimab was dosed as milligram per kilogram, and later the protocol was amended to give a fixed dose of 370 milligrams for a duration of 4 to 8 weeks. And this is what they found. There was an overall response of 61% in all these patients. Platelet count normalized in 50 to 71%. Renal improvement occurred in 67 patients except for the one patient who was dialysis dependent. Neurological improvement occurred in 50%. So the drug appears to be promising, but it appears to have a benefit specifically in hematopoietic stem cell transplant related TMA. There's no evidence yet of its use in solid organ transplant related TMA or any other type, so it remains to be seen if this will be pushed. Covasin was a drug which came from a British company. It's a thick saliva protein isolated drug, and what's most important is that patients who had eculizumab resistance because of the C5 variant would be expected to respond to Covasin. Now, the Covasin trial was initiated in our center. We screened 2 patients. We were in the process of screening the second patient when suddenly the trial was stopped across the world. And when I did a PubMed search, I found very little information on Covasin. I only found one case report of a young child of 3 years of age who had undergone a hematopoietic stem cell transplant, who developed both a TMA and a graft versus host disease. He was very aggressively treated. He was given infliximab, he was given eculizumab, which was started for a TMA which wasn't responding, and he did not respond to eculizumab. After which they looked at genetic studies. They found a significant heterozygous CFH mutation, and they also found the C5 variant arginine to histidine, which would predict that this patient would not respond to eculizumab, and so they switched this patient on compassionate grounds to Covasin. Now, the patient appeared to respond partially to Covasin, and then, very tragically, this case report says that the country, Great Britain, ran out of Covasin, and the patient could not be given it anymore, and the patient died. Crovalimab is a C5 inhibitor with a different binding site from eculizumab. There are 2 trials. It's predicted that it will be effective in the H85 polymorphism. There are 2 trials currently running, COMMUTE-A for adults and COMMUTE-C for children, and India is one of the countries in which this trial is currently running. Dr. Siddharth Chetty at Medanta is one of the investigators doing the trial with crovalimab, and Dr. Vala, who was here yesterday, is another. So this trial is currently running in naive patients. They're going to be naive. It's based on the fact that the Commodore trial, which looked at crovalimab in PNH, was successful, and also that there was a patient preference for crovalimab in that trial over and above eculizumab. So this is the current status of the trial. It's recruiting in multiple countries across the world. Europe will be least represented. Most of these trials because eculizumab is available as standard of care. So most of the trials are now concentrating on places which haven't got it. Whereas in adults, we have a 24-week trial with crovalimab. The naive cohort, 60 patients, switch cohort, 30 patients, and C5 SNP cohort, 5 patients, to prove that the drug is effective in this situation. In the pediatric patients, we are looking at 40 patients overall, and crovalimab will be continued likely on compassionate grounds to patients who do well. Finally, there is only oral complement inhibitor, iptacopan. Iptacopan is currently under trial again in India, or rather, recruitment has just recently been stopped in India. We had recruited 3 patients in this trial. It's the only oral inhibitor available. It's a factor B inhibitor. Our 2 patients who had failed plasma exchange both responded. 2 of the 3 patients who had failed plasma exchange both responded to iptacopan. So this is where iptacopan acts on factor B. This is the trial flow. We need to enroll the patient within 28 days of the disease and less than 14 days of plasma exchange being given. Iptacopan is given for 26 weeks in the initial phase, and then as a continuation phase, which all our 3 patients have entered, for another 26 weeks. At the end of the study, the company is likely to continue it for those patients who require. And these are the countries: India, as you can see, Japan, China and Hong Kong, United States and Brazil are currently in it. And the reason India actually met the target fastest. So they aimed to recruit 9 patients in India and they got to that fastest simply because the disease is more prevalent and the population is high. And so they've withdrawn, they stopped recruitment in India because they want an ethnic mix of patients from across the world in order to get the US FDA approval. So this is a summary of all the drugs which are in trial currently: iptacopan, pegcetacoplan, narsoplimab, eculizumab generics, which have been tried in PNH and have received accelerated approval for TME. Crovalimab, nomacopan, cemdisiran was tried but has been withdrawn in both the trials, one for funding and one because of COVID, and crovalimab. So if I come to summarize, I started with the KDIGO 2024 statement that's saying that TME. Last slide. Second last. I started off by saying that TMA would be more appropriate than atypical HUS associated with qualifiers to tell us about the pathogen. I didn't touch on the role of renal biopsy in TMAs because that would be a whole topic in itself. Although C5 blockade may be the cornerstone, in India at least, plasma exchange will remain a significant part of treating complement-mediated HUS, and perhaps the time is right for a randomized trial which will look at plasma exchange versus C5 blockade in antibody-mediated TMAs, and that trial can only come from India. Genetic testing should include whole exome sequencing and copy number variation, and iptacopan and crovalimab are currently under trial. I must acknowledge that I have received a huge help in managing my TMA patients from the lab, from my medical genetist, and all my colleagues and residents in the department of medicine.
Thank you, Valentine, for that beautiful journey down the complement lane. So, I just want to ask you, you're doing all this testing in your lab. So now you feel that because I think Raja had mentioned once probably we should all be willing to aim for the test because they are only.
As I said, the reference method is only being done. What we've done is we're trying to get for the reference method. We don't have to pay for it. So we are going to do it. But as of now, we are doing a modified commercial analysis scientific, and all the others are on NS. For instance, the ADAMTS13, we've validated that also. We're pretty satisfied with the way it's done. I'm not so satisfied with the safety factor. Dr. Bansal mentioned 50%. I looked at the data some time back. We've had 14 high values in 120 odds, which is over 10%. So perhaps, and Newcastle said they couldn't help us on that. So they said, you're using analyzer and we use a CPRCT like that. So when the methods are different, you can't match.
One more thing which
I went through the literature, the positive rates by C5, there's no way to say which is the gold standard. There's a paper which was sent to me, published in KI, I think in 2018. The positive rates are 25 to 35% with whatever assay you use, and no one can say which one is the right. That's the confusion that is in it.
One more thing is, said we should be using Plex and TMA. I agree with that. But supposing you know it's a genetic TMA and not an anti-factor, we still recommend Plex, especially as we don't have TMA.
So, again, for years before we knew about anti-factor A or genetic mutations, we empirically used plasma exchange, and some patients did this. Now, we published our paper on postpartum HUS. It's in Asian Journal of Asia Pacific Journal of Nephrology about 2 years ago. We had 21 patients, and 16 of them responded to plasma. Only 4 of them, and only 1 had an anti-factor A antibody titer of more than 1,000. 3 of them had values between 100 and 500. So I'm not even convinced that those were really anti-factor mediated. But 16 patients responded. The ones who didn't respond were the ones who had partial necrosis and biopsy. So, and we don't have the genetics of all those patients available as yet. We're still trying to run it. So some patients apparently do respond. How to find out? Well, one of the things that by plasma exchange, we do run into studies. So plasma exchange is not a treatment which is completely benign. Incidentally, children do much better at rally is concerned. There's hardly any rally in our pediatric, and the adult patients we get a significant amount of rally. So, plasma exchange is not a totally benign treatment. If you have a treatment which is targeted, which has a high efficiency, like eculizumab and the other, then obviously that would be the treatment. If you don't have it, you do perhaps something that has been seen to work. Narayan's group says that in their pregnant patients, they found 50% of their they had 7 postpartum, and 4 of them had high antibiotic. So,
the last part first. I mean, in genetic, known genetic issues, it is not taken to therapy or non-competent participants. One is better complementation to the classroom. And these kids would be really young too. Very low systems, that but you would definitely, if you can, you convince the family of taking it or participation required. Incidentally, I mean, in this day and era of social media, we have not got on YouTube safety height. We are the center as well. There are 3 centers in the country that have Covalumab. It's not just the blood safety at Vedanta and Kimari.
No, I know you.
So we all 3 are there together on this.
Yeah.
So we do enroll patients on Covalumab, and the response to eculizumab we have used in 5 kids, young kids, and Covalumab is dramatic as well. So while we remain proponents, I personally remain a very firm proponent of plasma exchange, that we can use safety and effectively. I also know that we have a place for these medications definitely. We use very judiciously, and there are many concerns around their usage in a country like ours. When we set down the doses of known doses like lower doses, we are going to cut one of them to Valumab and today. And suppose you have 90% disease which was managed with high IgA disease was managed with 2 doses of eculizumab and then stop with healthy after what do you do there? So there will be concerns around we need to have a rational statement coming from our society how to manage these medications. And so Banga is in the process of trying to get that done before there are really launches in the country. Because it's important to have clarity on how to use it, where to use it, and where not to use it. Back to the genetic cases. We have had occasions when we have kids that even in our units, get from lupus or other things happen. Young kids, plasma exchanges, there's a good audit paper from England that this classes are very problematic. So they would better. We soon after published another paper in JCA published, and it said that it's safe and effective, not just in anti-infective, but also in other forms of. Back to the question, anti-infective being prevalent in India and not elsewhere. The problem is the reverse of the anti-infective problem in the West. Since there are only 5-7 labs doing the action, they don't test for anti-infective antibodies. They go ahead and so they don't know who is anti-infective. When you look at the registry data from the AHA, the prevalence is fairly similar, 25% in pediatrics. When you go back to the 2.8 back, probably similar to what we have. Testing is important, timely testing before plasma exchange. On the other hand, we would disagree, and I think when I see that, we would disagree that adults should have that high rate of positivity. We do need to cross-examine the way the teachers are done between yours and our methods, that conversation, and there's an opportunity also to listen in the ICMR currently. Final last point, Dr. Tara's paper, retrospective report, profit. We did a prospective study around the time and publishing the epidemiology. We did say that 10 to 12 exchanges are effective and safe. We don't need to do this.
Yeah. So, as far that paper, if you're talking about from I think that's 2014 pediatric nephrology. It's very that paper actually did very, I would say, by the standards that we follow, pretty inefficient plasma. They didn't get to what they should have been doing. There was delay in starting, there was a short duration, abandoning, and they gave up plasma.
Yeah, I mean, that's why we took a button there and we have a
yes. And I agree with you that we need to collaborate. In fact, when I was at happening so long, 4 months ago, there was a demand that India is as large as Europe. So there should be, in each of the zones, there should be a reference lab. So even Narayan's paper, the one from SGPGI, I asked him, he said 50% of the samples were analyzed in KEM, 25% in AIM, and the remaining 25 somewhere in other labs. So that's what we said. Yeah, a shorter, longer half. So it allows once in 2 months instead of once in 2 weeks. So there is, fortunately, there is a KDIGO consensus on what you should do and how you group the risk. And Dr. Gulati showed yesterday, and I also showed it, but I didn't go into it because he had already done it. Eculizumab for anti-factor VIII antibody for TMAs, unlike C3GN, is very effective. So you have a factor VIII mutation, you have factor I mutation. If you have a C3 mutation, transplant them under cover of eculizumab. Yeah. Because I've been seeing the Apple trial, there are a lot of patients who are being enrolled on iptacopan for post-transplant TM, and so that we'll get some data from it. It's happening from Taiwan, China, and even from India. Some of the patients were post-transplant who have been enrolled for iptacopan. And as Aditi said, I would enroll a patient in a trial, especially an adult without anti-factor VIII antibody, and we did do that. Out of the patients that we enrolled on iptacopan, 2 of them all were dialysis dependent. One of them has a factor VIII mutation, one has a CD46 mutation. Both of them have failed plasma exchange and are off dialysis with iptacopan. So it looks encouraging. I don't know what the data is from other places. When they reach 50 patients, they're going to publish an result. Yeah, I think the question comes when you know today and when everything is available, then you can't sort of go and transplant the patient there and take it. It was all, as Dr. Gans, it was done in the days past when we didn't know. Yes, I agree with you. Agreed. Availability of testing and availability of drug has made it. Yeah, so all of them, we are supposed to vaccinate against meningococcus, pneumococcus, and H influenza B prior. And if that vaccination duration is from starting the drug, from vaccination to starting is less than 2 weeks, then we are supposed to give them antibiotic profile. So infections certainly. We've had one patient in the trial who has developed a pericardial abuse, and we're worrying that when I left him, we are working him up the Lobo. So infections, I think certainly will block off being a part of the innate immunity response. We could get.
I think we'll stop the discussion here and continue.